Hello and welcome. Today is a great pleasure and anticipation that we introduce our distinguished guest for the new session interview with the expert, Dr. Claudio Rabec. Dr. Rabec is an international recognized expert in the sleep medicine field. He is also recognized by his research and contribution to the diagnostic and treatment for the sleep disorders. Dr. Rabec actually is working at the pulmonary department of the University Hospital in Dijon, France. During today's interview session with Dr. Rabec, we will dive into the topic paramount importance of nocturnal pulse oximetry, a vital tool for home sleep testing. As we all recognize, sleep apnea remains a significant concern, often undiagnosed and unappreciated in its consequences. We will explore during this interview with Dr. Rabec the insights, the potential benefits of the overnight pulse oximetry as a simple and accessible non-invasive methods to identify sleep apnea causes and to start the treatment sooner. Warmest welcome, Dr. Rabec.
Thank you very much, Euda. I am very glad to be here, and thank you for this keen invitation. I will introduce some concepts about nocturnal pulse oximetry in breathing sleep disorder. I think that you have some question of experts that are sent you question to ask you question to response about some important topics in the use of nocturnal pulse oximetry in breathing sleep disorders. So go on with your question. Please, Euda.
Yeah, thank you, Dr. Rabec, and again, welcome. Yes, we have for this section the participation of different physicians from all around the world. So thank you so much to all the physicians who posed the question for that, Dr. Rabec. I think the beginning will be more to talk about how the pulse oximeter works. It seems to be a simple question, but today, the way it's interpreted in word, it seems to be worth it to have a review discussion with you, Dr. Rabec.
Yes, of course. In fact, how a pulse oximeter works. Oximetry uses a light source and a sensor, a photodetector, but placed on one side and the other of a pulsatile vascular bed. And this light consisting of two LED that emit two beams of light of different wavelengths. That is 660 nanometers for red and 940 nanometers for infrared. These two particular wavelengths are chosen because the absorption spectrum of oxyhemoglobin and the oxyhemoglobin are quite characteristic at these two wavelengths. So the operating mode of pulse oximetry is based on two basic principles. The first one is that the hemoglobin circulates in the blood in two different forms, oxy and the oxyhemoglobin. And there are also two different relatively independent blood flows. That is the pulsatile one, that is the arterial one, and the continuous one, that is the venous one. So the oximeter compares the ratio between pulsatile absorption and baseline absorption of these two different wavelengths. The ratio between oxyhemoglobin and reduced hemoglobin can be calculated for equation and to give us the oxygen saturation in the arterial vascular bed. This is the basic principle of functioning of pulse oximeter. that are now very, very useful and used in different settings in pulmonary medicine, and not only pulmonary medicine, but also in critical care and in general practice.
Thank you. Yeah, it is it's very worth it to review this concept. I would like also to, if we have now that we have the opportunity, how do you interpret the nocturnal pulse oxygenation? What is the threshold?
In fact, the threshold is important because the threshold of pulse oximetry, pulse oximeter is in fact dependent of two different things. The first one is the level of oxygen saturation, the level of baseline oxygen saturation. And the second one is the aspect of the curve of oxygen. That is, the first one will give you the state of oxygenation, and the second one will give us the events that could compromise the oxygenation of the blood. Those in the first one, we will evaluate the level of oxygen in the blood, and in the second one, we will evaluate the presence of some events that can compromise regularly and periodically the level of oxygenation. For example, in the case of an apnea or hypopnea.
And what other index do we should take into considerations?
There are some issues to interpret nocturnal pulse oximetry, and we have 3 or 4 important issues. The first one is the threshold of the saturation. That is, there is a controversy between the experts about what is the threshold of the saturation that we must take into account. That is, the most used threshold are 3 or 4%. Now, in most of papers and if most of experts agree that the threshold, the more appropriate threshold to interpret oxygen saturation, the fall in oxygen saturation is 3%. The other thing is what is the index? That is what we call oxygen desaturation index. How many desaturation dips in an hour are significant in terms of screening or diagnosing breathing sleep disorders. And here again, there are some controversy in between the expert about what is the threshold of number of oxygen saturation, and we can find in the literature values as 10 in hour, 15 in an hour, or 13 in hour, that reflects more or less the apnea-hypopnea index. But there are other indexes that were developed by some experts. That is, for example, the 90 or 94, 90 or 95 and 97.5 percentiles of what the number of oxygen saturation higher than 3 or 4, but also by using a standard deviation in moving windows to determine which are the interval in which the oxygen saturation, the dips are significant.
Very interesting. Did you have any slide that you can share with us that can show us in graphics exactly how do we interpret this difference in percentiles of the index for both numbers?
Of course, I can show that. As you can see here, this is a paper published by the Borsini teams that analyze different oxygen desaturation index as compared with the apnea-hypopnea index. And as you can see here, the most accurate threshold of a number of oxygen saturation is between 15.3 and 60. that shows a positive and negative predictive value that are above 90%. The problem of this paper is that those patients are patients with high pretest probability, and then they compare that with home respiratory polygraphy, and maybe it's more relevant to compare that with polysomnography, because we know that home respiratory polygraphy could underestimate the number of the events. Another interesting paper is, in fact, in this paper, they define that the in patient with high probability of OSA, that is a stop bank higher of 3, another Berlin higher than 2, and ODA 3 higher to 26 will lead to a reliable indication of CPAP without false positive in 55% of patients. So they propose a flow chart to decide the indication of CPAP in those patients by using this index, that is ODA index, in patients with moderate to high OSA pretest. And they define that if the patient have no moderate to high OSA pretest, they need benefit for a respiratory polygraphy or polysomnography. However, if the patient has high probability, high pretest probability, we can perform a pulse oximetry at home, and they choose the threshold of 12 OD3. If the patient has less than 12 ODI3, we need to perform a polygraphy and polysomnography. But if the patient has more than 12 of ODI3, we can envisage to use CPAP, to introduce CPAP by using a threshold higher to 26 in patients without symptoms, or less than 26 and higher than 12 in patients with symptoms or comorbidities. So they show that this technique is able to have an accuracy of more than 90% to decide CPAP treatment, that is to give us a threshold of apnea-hypopnea index that correspond to the indication of CPAP treatment. Another paper published by the same group, Parnigro in this case, proposed a multi-composite index. That is, it don't use only ODA, but use also the mobbing windows at 5, 10, 15, 30, and 60 minutes, and they measure the percentiles 90, 90, 95, and 97.5 of oxygen saturation number, more than 2, 3, and 4%. And again, they use a third element in this software of the oximetry by using a mobbing windows of 5 or 10 minutes. And they demonstrate that by using this multi-composite index, they showed an accuracy of more than 90% for OSA diagnosis in native patients with high pretest probability. This index was validated in one center. This is in monocenter studies in more than 1,500 patients, and now we are working with this team to validate, to make an external validation of this multi-composite index as compared with polysomnography in 2 other centers in Europe. So this is a very interesting thing, because in a period in which we move to a simplification in sleep apnea diagnosis, this type of tools in patients with high pretest probability could be very useful to move directly to CPAP treatment without using polygraphy and polysomnography. However, until now, most guidelines and recommendations of the scientific societies were not validate this technique until now and propose the use of polygraphy on polysomnography to prescribe CPAP. And this is the case also for the healthcare system that don't approve the use now of this type of tools to treat patients with CPAP without using a polygraphy or polysomnography.
Understood. Yeah, it's so basically I'm seeing that it's obvious the criteria to be using either the difference between using a simple oximetry or polygraphy versus when to recommend a full PSG instead. But based on that, what is your experience in the cases with patients with comorbidities like cardiovascular or cerebrovascular diseases, and what would you recommend for them in the use of the overnight oximetry?
In my mind, comorbidities don't lead us to change our interpretation of pulse oximetry, except in patients with, for example, obesity, in whom the accuracy and the feasibility of the oximetry is not so good because it's possible to lose the signal. But in fact, the comorbidities impact more on the decision to treat patients. That is, if the patient has an ODA higher than 5 or 6 or 610, for example, in the paper of Nigro and Borsini is 12 for decide the diagnosis and 26 to decide the treatment. The comorbidities play a very important role in decide the treatment. I show you again this slide that show that when we have more than 12 and less than 26 of ODI-3 in patients with symptoms of comorbidities, there is an indication of CPAP treatment with an accuracy of more than 90% of accuracy, more than 90% of accuracy. This is very important because sleep apnea is not a disease, it's a syndrome, and the syndrome that integrates not only a number of apneas, but also the condition of the patient, the comorbidities, and the clinical evaluation of the patient. It's for that we in each case, this oximetry need to be interpreted in a clinical setting. It's for that in this paper they propose to use the stop bang questionnaire and the Berlin questionnaire. Both questionnaires are very are validated against polysomnography, especially the Berlin questionnaire, and we know that now that stop bang higher for 3 and the Berlin questionnaire higher than 2 is related to high risk, to high pretest risk of sleep apnea. So in those patients that are the pulse oximetry is very useful. And in this context, I think that the comorbidities or the clinical symptoms are more related to the decision of CPAP than to the interpretation of the quality of the pulse oximeter.
Yeah, totally agree. And so based on that, what do you can share with us on the importance of the accuracy of the oximeter to detect or exclude OSA in patients outside the labs?
In fact, this is the algorithm that we use in our center. In France, there is not the oximetry is not validated to prescribe CPAP. The health authorities ask us to use a polygraphy or a polysomnography, but we use systematically nocturnal pulse oximetry more plus clinical evaluation. In fact, we use when we receive a patient with suspected for OSA, we see him in the clinical setting with the questionnaires, and we perform systematically a nocturnal pulse oximetry. And we evaluate by using the clinical risk and the NPO results if the patient has a high probability of sleep apnea or mild to moderate probability of sleep apnea. So in this context, when the nocturnal pulse oximetry is pathological, highly abnormal, and the patient has risk of sleep apnea, in clinically speaking, we can send this patient to ambulatory polygraphy. And this is our practice. Except in the patient that is, for example, a commercial driver, that is an at-risk job or condition in which if the patient is in this setting, we can't wait to polygraphy, and we introduce CPAP, and after then we perform the polygraphy to validate the indication and to validate the reimbursement of the social security, because in France, the CPAP is not reimbursed by the health insurance, only with oximetry. If the patient has normal or mild abnormalities, we move to polysomnography. And when the patient has mild to moderate clinical risk of OSA, and the oximetry is not pathological, and the patient has other suspected sleep disorder, in general, we address to the patient to specialize the outpatient clinic, especially for neurologists or psychiatrics, to evaluate if the patient has not another sleep disorder different from sleep apnea. This is our flow chart for using that. But of course, this paradigm is moving by new techniques that appear, and in particular by the development of new index in oximetry and the use of oximetry combined by other simplified tools. For example, the PAT, the arterial tonometry, or the high resolution oximetry. But we will speak about that. We can speak about that later.
Okay. Yeah. It does make sense, and I understood that varies between regions and countries. That I don't know if you jump in a little bit on the question, but it's just now that we're talking about on the clinical guidelines and the way that you guys work in Europe, and just thinking about in America or probably Asia Pacific and other regions. Will be more toward the how do you perceive now the technologies are advancing, are changing, are being modified, and getting more portable in the sense to access the patient where the patient is. What is your takeaway on the part of as technology advance? What would you see the critical the guidelines changing to in all around the world for approaching the patients of easy and fast diagnosed of OSA?
Of course, thank you for the question. In fact, we move now to a miniaturization of simplification of diagnosis, and mainly to diagnose this disease at home. Before, when I learned of this disorder, this sleep, I introduced myself in breathing sleep disorders. The paradigm was polysomnography for all people. But polysomnography has a lot of problems. The first problem is that we need to hospitalize the patient. That is expensive. The second one is the number of sensors. That is not a physiological sleep. The third one is the cost of the device and the impossibility to make more than one test for patient for night. So now there are a lot of development to simplify with the use of different tools and the use of intelligent algorithm but also artificial intelligence to improve and to simplify the diagnosis of sleep apnea at home by using even by performing even during several nights the diagnosis. This is very important because we know now that is a variability in terms of night-to-night variability in terms of apnea-hypopnea index in those patients. So to evaluate one patient only during one night and in a condition that is not a physiological one, a real-life one, is not the best way to diagnose sleep apnea. So now we have some tools that are able to combine with simple tools, simple sensors, the oxygen saturation and other sensors. For example, we have here two examples. The first one is the using of oxygen saturation, a sensor of body position and snore, and using the pulse arterial tonometry extracted by the oximeter. So this system uses only two signals. It's considered by the American Sleep Disorder Association and a level 4, that is a simplified system to diagnose sleep apnea. However, this system has been validated against polysomnography because it's able by use accelerometer and body position and pulse to build a hypnogram that you can see here at the bottom of the figure that is very well correlated with the hypnogram obtained by electroencephalogram. And you can see here that these path respiratory events are able to differentiate apnea and central and obstructive apneas by the modification in the pulse arterial tonometry. And so this is a very important thing because one of the limitations of a pulse oximeter is the inability to discriminate between central and obstructive apneas.
Yep.
Clearly, central apneas are anecdotal as compared with obstructive apnea, but some patients, mainly patients with heart failure, can present central apneas that are not able to be differentiated to obstructive apneas by only oximetry, pulse oximeter. The other tool that is interesting here is the pulse sensing time, that is the speed of transmission of the pulse wave from the heart to the oximeter, and it can evaluate not only arousals and quality of sleep, but also the change in intrathoracic pressure that could reflect an obstruction of the upper airway. So these tools, by combined with oximeter, are very useful to replace now polysomnography with a very, very well correlation by using only two sensors to detect, to put in the patients, on the patients.
Yeah, very, very interesting. So based on that, I believe that we all putting together all the necessary changes and consider the use of the overnight oximetry and the possibility to reduce cost, time for diagnostic and treatments. And can you share your experience in France in how do you think that can be replicated in other countries?
I think that there is now a democratization of this type of tools that allow us to simplify the treatment by systems that are not so expensive as compared by the polysomnography and polygraphy. So I think that it is possible when this system will be worldwide validated to be used to use these tools to diagnose sleep apnea and to treat patients with CPAP without needing a polygraphy or polysomnography. I think that this is possible, and I think that this is a change in paradigm now, because we move to the simplification in the diagnosis of sleep apnea. And my mind, in the next 5 or 2 years, 5 or 10 years, we maybe keep the polysomnography only to very difficult cases, and we will be able to have a diagnosis of sleep apnea with very high accuracy by using only simplified tools. And this is not a problem for countries, it's a problem of the availability of the tools. And I think that when the tools will be validated in clinical practice and in real life, they will be commercialized in most of the countries in the world.
Yeah, that's absolutely right. It's kind of like we're living in a world that we have to really eliminate all the barriers and frontiers to be able to provide and make affordable all the technologies for all the population, for sure. Another point is in talking about, and this is briefly, we can talk about of future validation of a PAT in creating another way for diagnose OSA severity. In this part, would that also represent a simple way to do it and a reduction of cost?
In fact, the answer is yes. The problem is that, as you know, all new technology is expensive. But when this technology is available, and used, the costs are clearly reduced. So the problem of this type of systems that only are not able to be used in several patients. It's one utilization for patients. So the cost now is because the cost, for example, for a watchpad or analysis now, it is one of the system is 150 euros in Europe. So it's expensive. It's as expensive as a polygraphy in ambulatory setting. So, but I think that as the system will be generalized, the cost will reduce. It is a law of economy, and the availability of this system and will be more interesting, more important. And as the interpretation is easiest because it's almost automatically the interpretation, and that is the comparison of those type of tools with polysomnography are were performed by using the automatic interpretation of the device. Of course, you can see and validate that by a human being, a human expert. But the comparison were performed between the human interpretation of the polysomnography against the automatic interpretation of the simplified tool. That is the same that show Nigro and Borsini with the oximetry. That is the automatic interpretation of the oximetry. There is not needing a human to interpret it. And you see, me, I am an expert to interpret the polysomnography. I spent at least 20 to 25 minutes for one patient. So it's a lot. Because I don't believe in automatic interpretation of sleep, for example. Yes. I validate sleep humanly. So this type of devices, as they use an automatic interpretation of the signals, they are able to spend less time to interpretation and to see more patients. That is less expensive. It's more medically, economically is more interesting because they have to the medical doctor to spend less time for one patient and to have a very accurate diagnosis. So I think that this is clearly the future in sleep apnea. But again, I think that all additional signals are important, but the most important signal is the oximetry now. Because without oximetry, it's not possible to have a diagnosis of sleep apnea. This is the crucial signal. So I think that all the developments that we see now and we will see in the future are development by integrating pulse oximetry with other sensors or other tools.
Yeah. Well, I mean, this has been fantastic. I mean, we can stay hours and hours and hours talking with Dr. Rabec, but I think to close this session, I wanted to go a little bit and touch once we had the diagnosed, then we go into the treatment, and then the utility of use, the benefit of use, the pulse oximeter. We know that nocturnal or daylight hypoventilation, as you mentioned, often didn't happen. It is recommended. So what is your clinical criteria when you're going to start non-invasive ventilation at home, that pulse oximetry should be used?
Of course. Thank you for the question. First of all, how to assess a patient for indication of home ventilation? I think that we need to integrate the patient in a multi-dimensional approach. That is to decide if the patient with chronic respiratory failure need home ventilation, need to, first of all, make a clinical evaluation, clinical symptoms, and not only symptoms, but signs, for example, in patients with neuromuscular disorders, if the patient is orthopneic, if the patient has a thoraco-abdominal paradox, etc., etc. The second key element is a pulmonary function test, of course. But even if the patient has a normal pulmonary or not so critical pulmonary function test and no clinical symptoms, I think that two tools are very important to decide the indication of non-invasive ventilation. The first one is arterial blood gases, of course, because when we ventilate patients with hypoventilation, so with hypercapnia. And in this field, a patient with more than 45 millimeters of mercury of PCO2 in restrictive disorder and more than 50 in obstructive disorder is a patient that needs non-invasive ventilation. The last but not least, a very important tool to decide the indication of non-invasive ventilation is oximetry. That is, pulse oximetry is very important because pulse oximetry is able to detect breathing abnormalities. Differently from arterial blood gases, is non-invasive, is easy to perform, allows continuous monitoring with an overnight trend, and can be performed at home. So in this context, there are some trials that evaluate the accuracy of oxygen, of pulse oxygen in evaluating nocturnal hypoventilation. And this is the result of one paper that we published several years ago, and that we compare oximetry with nocturnal transcutaneous capnography. And we evaluate two thresholds for oximetry that are at this time threshold that were used to define by the ACCP conference in 1999 the criteria of oxygen saturation or hypoventilation. And as you can see, when the patient in this trial that included 97 patients had criteria of nocturnal saturation, there is not false negative, and all patients were hypercapnic. I speak about patients with restrictive blood disorders. Of course, it's very different in patients with COPD that can have both mechanisms of hypoxemia, that is VQ abnormalities and hypoventilation. Those patients with restrictive blood disorder are only hypoventilation as the main mechanism of oxygen saturation. So the sensitivity of oximetry, pulse oximetry to detect hypoventilation is very, very high in these patients. but the problem of this tracing is that we have different patterns of oximetry. As you can see here, these are 3 different patterns of oximetry that we can show in patients that fulfill criteria of nocturnal saturation. The first one is continuous saturation. The second one is saturation dips. And the third one are episodic desaturation, mainly during this period that are corresponding in general to REM sleep. And in fact, these patterns, as you can see here, are not able to discriminate the underlying mechanism because, for example, this desaturation in those patients, mainly in patients with COPD, of course, but also in some patients with respiratory disease, are maybe hypoventilation, but also sleep-induced BQ abnormalities that are hypoxemia that is not related with hypercapnia. So the pulse oximeter is not able to discriminate the underlying mechanism explained the saturation. Of course, if we take into account only patients with restrictive disorder, pure restrictive disorder, for example, kyphoscoliosis or neuromuscular disorders, this problem is not a matter because those patients in general, when they desaturate like that, those patients are hypoventilate during the night. The second pattern is this pattern, that is a typical pattern of sleep apnea that could complicate those patients. That in sometimes there is something that led us to introduce at least CPAP, but frequently non-invasive ventilation because those patients are not only the saturation dips, but also a level of saturation that is low. And in this context, this pattern of oximetry is not able in those patients to discriminate between obstructive and central apneas. So this is a limitation of the oxygen desaturation. That is, it's very not sensitive, but specific for hypoventilation, but it's not able to discriminate the underlying mechanism that led the patient to this disorder. Yeah. So the second thing is, what about the patient with a normal nocturnal saturation? That is, are we able to confirm that those patients does not hypoventilate? The answer is not, because as we know, the aspect of the curve of oxygen saturation is sigmoidal. I will show that you. This is typically the aspect of the oxygen saturation curve. During the first part, that is when the level of saturation is high, you can hypoventilate, and when the patient have 20 millimeter of mercury more than PCO2 has 20 millimeter of mercury of PO2 lesser. So this patient, when they saturate here with hypoventilate, there is not expression of oxygen desaturation. No. When the patient is in this part of the curve, a very, very little modification of oxygen saturation could explain that the patient decrease a lot oxygen saturation. Let me show you some example, and here you can see a patient with an almost normal oxygen saturation. This is a neuromuscular patient, a myopath, in which there are some very little notch, but there are not criteria for oxygen desaturation in those patients. But when we perform in parallel capnography, we can see that this patient hypoventilate, even if the level of saturation is normal, because we move in this part of the curve of oxygen, and in this part of the curve, we can increase 20 millimeter of mercury PCO2 without reducing oxygen saturation. And in our paper, we show that when we compare oxygen saturation with TCPCO2, a normal nocturnal saturation in patients with restricted disorder, mostly neuromusculars, is not enough to eliminate nocturnal hypoventilation, because as you can see here, when the patient has no criteria of nocturnal saturation, that is less than 30% of the night spent with saturation below 90, 1/3 of those patients hypoventilate during the night because they are in the upper part of the curve of oxygen saturation. So if I summarize that, we can see that abnormal oxygen saturation is in those patients is related, very, very highly related to hypoventilation. But when the saturation, the oxygen saturation is normal in patients with respiratory disorders, we cannot exclude nocturnal hypoventilation, and we need to move to transcutaneous capnography.
Oh, excellent, excellent. Okay, I think that's going to conclude this session, and I don't know if you have some summary that you want to leave us, Dr. Rabec, from today's topic.
I think that if I have to summarize, I can see we didn't speak about the interest of oximetry in the follow-up of those patients. I think that it's very important to emphasize that oxygen saturation is a crucial tool, not only to detect hypoventilation and to detect sleep apnea, but also to monitor those patients. It's very, very important to use oxygen saturation in patients on devices treated by respiratory devices, but because it is a very important tool to detect abnormalities and insufficient treatment. That is, in our experience, we follow up those patients with clinical evaluation and oximetry and arterial blood gases in the case of ventilated patient, and pulse oximetry is a crucial tool to apply in patients that we follow up for long-term ventilation. If I have to summarize, I can see that nocturnal pulse oximetry is essential as a diagnostic tool to screen OSA in patients who are at high risk and to prioritize patients, to orientate them to polygraphy and polysomnography. But maybe in the next future, we could use this tool as a diagnostic tool to confirm or to exclude sleep apnea and to introduce CPAP in our patients. As a diagnostic tool, pulse oximetry is very important also to screen patients to the indication of home ventilation. Secondly, this pulse oximetry is also very useful to assess efficacy of CPAP or NIV treatment, integrated with clinical response, and in some cases, for example, in patients with on non-invasive ventilation, integrated by PTCO2, that is transcutaneous capnography, and the data obtained by using built-in devices coupled to the ventilator. And its role now as a diagnostic tool to confirm exclude OSA needs to be defined, but I am very optimistic in this context, because I think that in the next future, we will use oximetry, maybe combined with other sensors, simplified sensors, to clearly diagnose sleep apnea in most of our patients suffering for this disorder.
Oh, that was absolutely great. Thank you so much, Dr. Rabec. We are really grateful you spent some time with us today, and we're looking forward for another session in the future. Thank you so much. That ends this session. Goodbye.
You are welcome. Thank you very much, and I hope that my presentation will be appreciated by my colleagues.